Hello to everybody. I think everything has been said. So let's try to explain a little bit about Vega. It's a bone level implant, and now there is another new design of this tested bone level implant from Klockner. I have to say thank you for inviting me also to share this small presentation. So everything it's about stability and aesthetics. We all know that implants osseointegrate, but what we are trying to reach now is aesthetics. Aesthetics not only in the posterior, not only in the anterior, but in the posterior zone, because premolars and molars should always look aesthetic. Okay, so what we have to do is think about what are the factors that determine the soft and hard tissue stability in order to get this aesthetics. So we talk about blood supply, implant design, connection, platform switching, and the implant placement. We will stop in detail with the implant design. We do have bone level implants, and we have been using tissue level implants for a long time. Until we had bone level implants, we were using also tissue level implants, placing them crestal or even subcrestal without knowing what was going to be happening in the tissues. But now we do have those implants, and what we know is that it's very important that the bone coronal design is especially designed to stabilize bone and also to let collagen fibers to get around the implant. So the soft tissue protects the hard tissue. There are a lot of different designs, but we know it's not only a thing of coronal design, but also body design to transfer the occlusal forces into the bone. So there are no micro movements, okay? This is the beginning of the primary stability, and it's related to anatomical considerations and the design of the implant. We have a lot of shapes, tapered, parallel, combination of those, and sometimes we don't know what to choose. Now we are mostly orientated to use tapered sides to get this very high primary stability, because we are all tending to do immediate loading. Okay, thread height is different between the types of implants. You get each brand of implants has its own thread heights. This makes a very big difference in primary stability and also in the insertion torque. So we have to take care about that and know what's going on. Related to soft tissue management, when we use tissue level implants, we cannot manage with the healing caps, with healing abutments. They make cylindrical in most cases, maybe a little bit conical in the upper part, but not too much, because the emergence profile is done by the shoulder of the implant mostly. When we use bone level implants, we can manage from the beginning. We can use different type of healing abutments, not only in length, but in width and also in shape. And now we are starting to print those healing abutments. So in combination with temporary restoration abutments, we can manage our soft tissue from the beginning, but this can be done with the bone level implants. Then we have to look at the connection. The connection, we have external and we have internal. The previous speaker, Javier, has clearly stated that internal connection is better for everything, for occlusion, for the distribution of the forces. When you saw that shim of the table pressing with forces and the table next to a wall. So we need to have internal abutment connection. In single implants, this is a must. We have to have it, okay? So what we know, this is a very classic photo of the external connection, is that there are big micro gaps. These micro gaps result into bone loss. Okay? There is a lot of stress on the screws, and we have, as I said, bone crestal loss. Okay, when we use this kind of internal connection, what we know is that we have a better seal of the implant. It reduces the micro gap, it increases the stability of the abutment connection to lateral forces, okay? And what we know is that when we chew, those forces get inside the implant through the abutment, not through the screw. The screw is just a stabilization piece. We only make the restoration, we put it in the implant, we screw, and even taking out the screw, the restoration will stay in place. It's like a cold welding. But this is something that can be achieved only with not copycats, okay? We have to use original components. We have to mill in the correct milling centers. Otherwise, we will lose all this kind of setting and this kind of friction. So you can see it here on the left side, the restorative abutment, and on the right side, the implant wall. Okay, this is the micro gap. And we know that bone level will sit at last 2 millimeters above this connection. So it's better to have this kind of implants like Vega and Vega Plus that I will show you later, with a high primary stability and conical connection with a good sealing of the restorations. Okay, platform switching. We know that the platform switching concept was introduced in 1995 mostly. And what was stated is that the space, the biological space is not only a vertical concept, it's an horizontal and vertical concept. So what we try is to place the gap as far away as we can from the bone. And this is an option that we can only do when we have internal connection and bone level implants. Otherwise, if we have a tissue level implant, the gap will start here, okay? Because this part of the implant, in most of the cases, it's polished. So this is for the soft tissues, not for the hard tissues, okay? So we know that this is a very good way to avoid bone resorption. This is called offset. We have the horizontal component and the vertical component. So we have to be 2 millimeters away from the bone, from here to here. Okay, so what did Klockner introduce in the market? In 2015, they introduced Vega. Vega is a bone level implant with different kind of diameters, okay? With a connection, conical connection and an internal X to settle and to make the indexing of the pieces, okay. They also introduced the optimum alloy. It's an alloy that gives more strength to the implant. 64% plus resistance compared with the old alloys or the old titanium. Okay, in 2016, they decided to introduce the Contacti surface. This is a bioactive surface. This has make the healing periods get shorter and shorter. At the beginning, we had to wait about 6 months when we place an implant in the early 90s. Now, with 4 weeks, it's enough with this kind of surfaces. The Contacti is a bioactive surface that accelerates biological stability to 4 weeks. In most of the brands of implants, we have to wait 8 weeks. At the end, the amount of bone will be the same, but the beginning, at this critical 3 to 4 weeks, there is a huge amount of bone surrounding the implant and in contact to the implant. This is obtained by 2 processes. The first one, the classical one, shot blasting, okay, that makes this 1.5 Sa roughness, okay, of microns that let the bone heal, excuse me. And then there is a thermochemical treatment that gives negative charge to the implant. This is what it's really new in the Contacti, the thermochemical treatment, okay? I will show you a video later. Okay, this makes attraction of ions inside the implant. It's like blood attraction. So what it makes is absorption of proteins to start bone healing. What we need is proteins, we need collagen to establish a membrane, a collagen net so that osteoblasts can go near the implant. Okay, this is the conventional draw where it gets through time and what we get is bone stability. At the beginning, we know that we have a high bone stability, primary stability due to bone compression, okay? But as time goes by, we are going to lose the bone that it's directly pressed over the threads of the implant. Okay, this is about the 3rd to 4th week. With this kind of surfaces, this period shortens, and we will not have that big bone loss between the 3rd and 4th week. That's why what we see is that the bone implant contact around 2 weeks, it's 75% higher, okay? So you can see these images from left to right, and it's the way and contactee surfaces behave in some kind of simulation of the human body. And you can see that the implant attracts proteins and also attracts human fluids. So it gets faster osseointegration. Okay, this is the video, so I will let it just play. Okay, this is what I call for cell surfaces. They just have to be charged negatively, and then it's like a positive, negative, positive, negative, always the same. So at the end, what we do is just call the osteoblasts to gather around the surface of the implant to start bone condensation. So at the end, the implant would get stable at the beginning due to its design, but then it will have secondary stability due to the chemical treatment. Okay, so with Vega Contacti, what we know is the easy of using it, the same as we did without it. We have a very high stability due to the design, not to the surface, but it's predictable, safer, and faster. So we can use it always, but mandatory when we have those patients with bone healing complications, okay, like diabetes, for example. Today, what we have done is create a new kind of implants, a self-tapping implants with a higher bone stability, primary stability due to its design. And I will try to explain it a little bit with some designs and some videos, okay? This is the new Vega Plus. You can see that there were two objectives when they decided to develop this implant. It has to look like a tapered implant. That's right, but then it has to be a tapered implant. So this was the objectives, and they were achieved, of course. Some in vitro tests were done with different designs to compare the design and the torque of insertion of Vega conventional implants and this new Vega Plus. And what they found in these tests was that there was a higher insertion torque of the implant. They were tested in the 4 diameters, 3.0, 3.5, 4, and 5.5, different bone qualities, type 1, 3, 4. This is a very nice implant for type 3 and type 4 implants. they get very, very high primary stability when you under drill. I will show you it later. And then we have to modify those drilling sequences to get the best of this implant, okay? So sometimes we will do normal drilling in type 1, might be in type 2, but we will do under drilling in type 3 and type 4. Afterwards, I will show you a case, just drilling with the first or 2 drills, I placed the wider implant, and it got a high, very high stability. The insertion torque, it's 23% plus stronger. It has a 2.0% of more primary stability, okay? And we will talk about the design of this implant. The alloy, it's optimum alloy. I have said before, this alloy gives more strength. So it makes that even in very small diameter implants, the resistance of the implant is very high, so will not break. Of course, we have to think about overloading, but we don't know how much overloading really is. Javier said it before. We have the whole range of diameters. You will see that the way we talk about this implant, it's a little bit different. We have to add 0.1 millimeter. It's 3.1 instead of 3.0, 3.6 instead of 3.5, 4.1 and 4.6. So when we use Vega implants, we will have 3, 3.5, 4 and 4.5. And then we have 3.1, 3.6, 4.1 and 4.6. This is the only difference. Of course, the difference is in the design. We have lengths 8, 10, 12, 14 millimeters, okay? We can have it in shot blasted or in Contacti, but we will not find Contacti in 3.1. Why? Because of the thermochemical treatment. Cannot be done safely without altering the structure of the implants in the 3.1 at the moment. What we know is that we have this converging color. This is stated in the literature that lets bone heal better around the implant and reduces the stress on this part. Also, these horizontal lines or rings are made for the stabilization of the collagen fibers. So this is designed to stabilize and maintain the cortical bone. Then we have this called asymmetric V-thread shape and the apex, okay? I will talk about it later. This means that the distance in between these threads will help us to have primary stability. It will get in the bone with less torque, but it will get more strength into the bone, okay? These kind of designs with these helical channels that turn anti-clockwise make as a compact of the bone. The bone gets inside these channels and goes inside these spaces to give more primary stability. Okay, these threads also make that the insertion in the bone is easier. When we talk about the internal design, we have this internal hexagon to index the structures. It helps us to manage with the prosthetical components, okay? And then it also helps to make anti-rotation inside the single unit structures when we place single crowns. Okay, we do also have the platform switching concept. It's about 0.3 in the thinner implants and about 0.5 millimeter in the thicker ones, okay? In these two cases, the restorative components will be the same, but this and this will be designed exclusively for the 3.0 and the 3.1 and 3.6. Okay, the internal cone gives perfect fitting and perfect sealing. So it will make like a cold welding of the restoration. So there will not be microfiltration. This is critical. This is critical for the bone stability. You can see here, it's at 10 degrees conical design with a perfect sealing. And when you don't use the original components, what we have seen is that in many cases, it's about 12 degrees, and you will see what happens. This is the 10 degrees, and this is the 12 degrees. Have a look at that part of the connection. Perfect sealing, okay? So there's no microfiltration of the bacteria. And have a look at this. The gap exists. So when you use bone level implants, it's mandatory to use even milled abutments by the company or just original components. This is the best way to avoid microfiltration. You can see it here. You get spaces where the bacteria can stay, and you may have bone loss. Okay, surgical features. Both implants use the same surgical box. There's only one kit. You don't have to buy anything else or anything new to place Vega Plus implants. What we will have to do is to change the protocol, the way we place the implants, okay? So in many cases, depending on the bone density, we will have to under drill. This means when you use Vega, there's no need to. When we use Vega, Vega Plus, it's a must. We have to under drill. It might be that in type 1 bone density, you should just drill the correct, use the correct drill instead of under drilling, but this is not very useful, usually. And you will get 34% more contact surface when you do the under drilling, okay? You have to also have a look at the insertion torque. Don't put it in at very high torque. The prosthetic solutions for Vega and Vega Plus are the same. They have the same components. So there's no need to learn anything new. There's no need to buy any transfer piece, new replicas, or whatever. Your lab will never be so pleased because they will not change anything. As a summary, we can say that Vega Plus has a high mechanical resistance in all diameters due to the due to the optimum alloy. The surface treatment that we can use are shot blasted, the conventional one, and the new one with the Contacti, reducing the healing periods from 8 weeks to 4 weeks. The surgical box is the same. The diameters for all solutions. I will show you some cases with very narrow spaces in a inferior central incisor with a 3.0, in this case it's a 3.1 implant. And you know, in many perio cases, the crown is very long and we have to use very, very thin implants. And what we want is to do screw retention, not cemented. Then the optimal insertion torque for immediate loading. When we do immediate loading, we want a very high primary stability to be able to charge the implants with our crowns. It might be that we do it single or multiple. And the high mechanical stability, what we have seen with the Penguin ISQ test system is that we get higher primary stability when we use Vega Plus than when we use Vega. And the same prosthetic solution, so there's nothing to change. Okay, I will try to show you some clinical cases in detail just to see what we have done. They are all surgical cases. This is a patient who has to have this premolar extracted. This is the root, and we decided to place an implant after the extraction. So we made our CBCT, our pre-planning, first in 2D and then in 3D. We decided to go 2 millimeters deep from the level of the crestal bone. This is the mental nerve. And then we switch to the surgery. We just make an extraction very carefully, trying to avoid any fracture of the buccal or lingual plate. Then we eliminate this soft tissue surrounding the root. We clean it, and then This is our pilot drill, just trying to drill a little bit to guide the implant placement. This is a 3.3, so we will place here a conventional implant. We will place a 3.5 implant, but we decided to under drill 2 steps. So we placed a 4.6 millimeters in this case, okay, with this drill. The drill for the 3.5 conventional Vega implant, we decided to be the last drill for the 4.6. So we place the implant about 3 millimeters not subcrestal in this case, but submucosal. You can see it because this healing abutment height is 3 millimeters. And then we don't put anything inside here. And we don't press also, we don't even press the soft tissue to get inside, but like we did before, because Tarnow said that there's no need to, we have to stabilize the coagulum. We can just place some collagen here, collagen sponges, and then let it heal. We get an ISQ of 68, just under drilling 2 steps, okay? 3 millimeters here, about 1.5 or 2 millimeters subcrestal. Another simple case, this is a mixture of different sites. In this case, we extracted the premolar and we also placed an implant in the molar, but I will show you only the post-extraction site. We decided to put the implant in the palatal root. We just drill with a 3.3 and then we place the 4.6. Again, you can see here, this is number 2, so this means this is a 3 millimeter healing abutment. We just place the implant, collagen sponge, and let it heal. On the lower side, we did the same. We extracted the root. We placed a 4.6, 10 millimeters length, filling all the gap. This is a very common case where we think about extracting the premolars and placing implants. Some time ago, I just extracted the tooth and let it heal before placing the implant because there's no way to use short implants to have primary stability, and we had to use long implants. But this was not what I like because we had the mentor nerve. So now what we do is we get out the root, we place a shorter implant, maybe 8 millimeter implant with a wider diameter, and we place it in the mouth and just let it heal. This is another post-extraction site, okay? But in this case, we decided to put it in in healed bone in one side and non-healed bone on the other side. So you can see here the images, the post-extraction sites, okay? And the primary stability that was stated with the Ostel ISQ, the Penguin ISQ. This is a more complex case. This is a CBCT with a superimposed STL file of the intraoral scanning of the mouth of the patient made with a Carestream CS 3700. Then we decided to just plan the implants. We can see here, post-extraction, the patient was having 2 previous implants, so we extracted both canines and placed immediate placement and immediate loading. So first, we plan our surgery. We choose the right implants. In this case, it's a 4.6, 10 millimeters length. This size. We can do it also guided surgery. I will show you some cases later. But this case, we decided to use it by hand. So we just designed also our restorations. You can see them. This is the STL file to be sure that the emergence profiles fit in the correct place. Then we did the guide. You can see it here, okay? But only for piloting in this case. We didn't do it fully guided. There's no need to, because it's going to be a post-extraction. Then we also made a PMMA restoration following the protocol that Dr. Fabrega stated before, just placing the implants. In this case, it's in median loading, not delayed, but we use always PMMA interim restoration just to let the patient adjust the occlusion. This is the only way we can, at the end, achieve a good steady restoration without touching any zirconia if we decide to do it in zirconia. So we just took the restoration out. You can see these 2 roots, failing roots on the other side after the extraction. Then we use our guide just to stabilize the first drill. There's no need to, but we were trying also these kind of guides. Then we place the implant. We have this torque control. We get into 30 to 35. We can test the primary stability, and then we can put the restoration on top, fix it. We use also the two osseointegrated implants to give more stability and to avoid these cantilevers. We didn't want to place the implants on these sides to be away, far away from the other implant, to have as much bone in between the implants as possible. Then we just made it by hand in the lab, the emergence profile, and we place the restoration. And this is enough for the patient to get out, home, and chew. This is the X-ray, just to see everything is okay. And then another case. This case is also one implant placed post-extraction, and the other one, it's in healed bone. We get the CBCT, we get the STL file, we merge bone, we merge both, Then when we merge both, we can use our, in this case, it's a SMOP 3D guided design software. And then we choose our implants in Carestream PDIP. We have the geometries of the Vega and Vega Plus implants available in this Carestream's PDIP software. Then we design where we are going to place the implants, also the virtual crown, and then we export to SMOP. We open the SMOP software, we have the implants there, the geometry of the Klöckner implants, and then we design the guide. The guide is designed, in this case, also only for piloted, because I think the most important thing is to be able to decide the correct axis, the 3D axis of the implant. And the length we can decide by using drill stops inside the mouth. Okay, so this was just testing. We have a 3D printed model to test the fitting of the 3D surgical guide. Everything fits perfect, so we have to be sure everything fits. Then we just place it in the mouth. We didn't raise a flap in this case, but we can. There's no need to do blind surgeries, even using this kind of guides. I don't think the guides are only for blind surgery. We place both implants, and you can see here the perfect placement and a high stability. Only with the pilot drills, this is the 2.2, we place the 3.6 implants, giving a high torque of insertion. We can even place 2 temporary restorations on top and let the patient go home. Another case, this case was the absence of a premolar with a small cyst. You can see it here through the CBCT. We merge both images. We can put or draw a virtual crown to see the emergence profile. Nowadays, with this correction of angulation, we can perfectly restore this implant, having the chimney in the middle of the occlusal part of the restoration. Okay, you can see here, this was where the tooth root was at the beginning. This is a 21-day surgery, so it's an early surgery. We design also our guide. You can see it here, the fitting of the guide. This is the 2.2 drill going inside the guide. We just drill the 2.2, then we get the 3.3 and place the implant. In this case, we decided to place the 3.6 implant. We also tested the ISQ stability, and again, 3 millimeter implant placement subcrestally. It might be 2.5 or 2.3 millimeters, but here you can see the 3 millimeters. Another case that we can see, this is the same, this is routine in our office. We have to extract this root and then place also an implant here. We design it, we have the root, and we have the native bone with a virtual crown. Once again, we design our guide. We plan everything in the software. We know that planning is the key for success. This is prosthetically driven implant placement. We just design our guide once again. We print it. We place it in the mouth. We extract the root without raising any flap, but we can raise flaps. There's no problem in raising flaps. I think it's better not to, but we can when we have enough width. We place a implant 4.1 in the palatal part of the root, and then a 3.5. Why? Because we want to leave more space. We didn't use a 3.6 implant because it was much difficult to achieve parameter stability because this was wider than 3.6. So at the end, we got a 4.1 and a 3.6. With a high primary stability, there's enough space between implants and between implant and tooth to have bone, native bone surrounding, so the healing will be normal. Another case, this is a very complex case because this patient had a failure in his lateral inferior incisor, and there was not enough space to place a conventional implant. So we decided to use this 3.1 Vega Plus implant. This is made of optimum alloy with contacty surface, without contacty surfaces because there's no contacty surface in this 3.1. So we extracted the tooth and we just placed the implant in a very, very narrow space. You can see it here. There is no space. So we just extracted the tooth. We get the first drill. Then we test. Everything was okay. We placed the implant. We made only a suture and it's done. It was much more complicated to do the restoration than to place the implant because there was no space for the abutment. You can see also here a very high healing abutment. So with this case, this is the end of my presentation. So thank you very much for attending, and I will try to answer all the questions that comes out. Okay, Javier, it's your turn.
Giuliano, muchas gracias. Excelente como siempre y innovador. Tenemos aquí 3 preguntas para ti.
Excuse me, I will try to switch to the presentation because it's not working. Something it's not working. Video. Yeah. 1 second. Can you see me?
Yeah, but it's small. Yeah. I see you. You're still sharing your desktop?
I will stop sharing it. Excuse me. Done? Yeah?
That's all right.
Okay.
So, Giuliano, thanks a lot for your presentation. Very innovative. And I wanted actually more of the digital stuff. We have a question on that also. So there is a first question asking you whether if you think you have reached with the Contacti osteoinduction, whereas other implants has only on osteoconduction property.
Well, this is not a very easy question because we cannot say that it's an osteoinductive implant. It's of course, osteoconductive, and what I say is osteoattractive. It attracts cells. So this is not a biologic device. This is metal. This is titanium. So the only thing that we can do is chemical reactions. That's it. Okay.
Fair enough. There is another question. When you place short implants like 4.6 by 10 in a premolar, to avoid mental nerve, what happens to the crown to root ratio?
I think, Javier, we have discussed a lot about this when we use short implants, and now crown to root ratio is not a must because we know that the surfaces have developed so well that we have more bone implant contact in shorter implants that we have in the past. In the past, our gold standard was 12 millimeters. Now our gold standard is 8. What I think nowadays at the tooth ratio being even 2:1, it's enough. Okay.
Yeah, I think it's definite that crown to root ratio in implants does not work really as the same as in teeth. So we have to change our paradigm in that. Now the next question is about the SMOP. The question is if that software works only with CarStream.
No, it's an open source. You can use it with we are using also with other scanner. With your scanner, we are doing some surgeries. With the Medit one, you need only an STL file and a CBCT. You can merge it in the software and then design for whatever implant you want to. There's no need to have CareStream, but it's the way we work. It's our workflow. It's easy because from CareStream, that it's a very simple CBCT analyzing software. You can plan your implant in, let's say, 1 minute or 2 minutes, and then export it to this software, and then develop the guide. It's an open guide. That's why I use it. Okay.
All right. And the last question I can see here is if you ever graft the buccal socket in the immediate placement on the multiradicular tooth.
Nowadays, no. What I do is place collagen sponges. If we try to put some xenografts, what we have seen is that it takes longer to heal. If we press the soft tissue to get near to the implant, what we have seen is that we put some connective tissue near to a socket that it's healing, so it will get full of connective tissue. But what we need is to stabilize the coagulum. What we do is something to stabilize the coagulum. That's enough. When we have coagulum, that is bone, so there will be bone. So I don't use it as a routine.
There is another question in that sense. If you in the lower cuspids manage the buccal bone gap for long-term bone preservation around the implant, I guess it means if you can actually do you feel the gap with some biomaterial?
That's what I said before. Sometimes I have to when the space is very, very big, but just to avoid getting food inside. What I like most is placing some kind of restoration to fill the gap, like the technique that you talk about, the 3-step technique. Place the implant, play the restoration, and then manage the healing abutment to cover all the space. There's no need to have, because this implant gives a lot of primary stability. So it's stable. If the coagulum is stable, you will have bone. Just close the space. There's no need to graft it. It's my opinion.
Talking about stability, there is another question asking about what would be the maximum torque that you apply while using under drilling technique?
I think more than 50 newtons, 50 to 60 newton, it's too much. In Europe, we are used to use lower torque insertion pressure, but in the States they do higher. So I think 60 would be enough. That's the limit in my opinion. There's no need to under drill so much. When you just put the implant and start pressing and it goes 50, 60, and you have to do a lot of pressure to get the implant inside, it's better to take it out, then let's say drill again and then place the implant. Okay?
Okay, and then a question comes from me regarding what you see coming, the difference or the future for guided surgery versus pilot surgery.
Excuse me? The difference between guided and piloted?
Not the difference, but what do you see coming as a standard of care, or what we are going to be using more in the future?
I think the biggest problem is that people want to make blind surgery. Mm-hmm. And this is a mistake. They think that having a guide makes or allows everyone to make surgery. You know, we know each other. You are a restorative doctor, and you always look about the restoration before thinking even about placing an implant. And now what we are seeing is that the GPs, the general practitioners, want to do this kind of fully guided implant placement just to place implants. So in my opinion, with the pilot guide should be enough. I don't know if you agree with me, but what we need is the axis, the correct position to have the emergence profile where it should be. Then we can raise a flap or use drill stops. Nevertheless, in some cases, if you want to place implants and the patient gets tired, it's better to do it fully guided because it's less time consuming, but that's it. Because we don't have the restoration milled in a table and then we place the implants fully guided and then we place the restoration with perfect fit. That's not true. We have seen it in a lot of articles, but this is not, they say they don't fit. So we have to look at Facebook dentistry.
Okay. I have a question here from one of the doctors are connected. I'm not sure if I understand it, but there is a question about the Vega Plus design versus the design of the drill. I don't understand very well. I think the question is whether the new implant goes okay with the old drills or with the previous drills.
Yes, what I say is that the drill system or the surgical box is the same one. What they have developed is just a different shape and of the threads and a different path of the shed. That's it. There's no need to have special drills. I know there are systems that have developed because new implants with new drills, but in this case, it's not. It's very simple. You just buy this kind of implants and the drill and place the implant. That's it. That's it. That's why it's so easy to switch to these implants.
All right. I have no more questions for you, and I think that's all
the
for
end
us.
Of the story.
So we can go back to the presenter. Ellie, are you around?
We are not sure if he's here. So Javier, if you want, you can close it. You can close the event.
I think Ellie is there.
Yeah.
I see. I don't see his picture though.
No, neither do I.
Well, then we're ready to close up this session. We hope it was very useful for you. We hope to maybe be in touch and in the near future. This is opening a new source of communication that I'm sure we will all be using in the future, especially now that we won't be able to travel for quite some time. So we're here to help you. Anything you need, you can contact through Klockner, and we will be helping you with any of your questions all around. Thank all for connecting. We have had almost 300 participants in this meeting, so we hope to see you soon.
Okay. See you again. Bye.
See you. Bye.
Bye.